We want the other thing that we want to do, another key for our success. Welcome everybody to our on-demand course here, Physiatric Practice in the Skilled Nursing Facility, What It Takes to Be Successful. As you can see, I'm not really in San Diego, and probably neither are you. But we do have a great group of talented people here to present to you in this next hour or so. And we really hope to just impart some of our wisdom to you in terms of what we've learned over the years in being successful practicing in the skilled nursing facility. So without any further ado, let me go ahead and get started. If you don't know who I am, I'm Dr. Steve Natz. I'm Chief Medical Officer for Integrated Rehab Consultants, and my financial disclosure is that, of course, I am employed as the Chief Medical Officer for Integrated Rehab Consultants. So you may already know this already, but significantly more inpatient rehab occurs today in a skilled nursing facility environment than in an IRF setting, an inpatient rehab facility. We all trained and grew up in the inpatient rehab facilities across the country. They're generally hospital-based, and a lot of good rehabilitation still goes on in an inpatient rehab facility. But much more inpatient rehabilitation is actually occurring today in America in a skilled nursing facility. Yet, as opposed to the inpatient rehab level of care, physiatrists have no mandate to be involved in SNF-based rehab. You probably may recognize that in an inpatient rehab facility, there needs to be a rehab physician involved in the care. There's no such mandate in a skilled nursing facility environment. So how do we as physiatrists become involved in this important level of rehab care? Well, just to give you a little background on me, essentially about 10 years ago or so, I followed my patients into the skilled nursing facility. I was working in a hospital and a hospital system that had an inpatient rehab facility of which I was the medical director, and I was doing consults in the hospital, and I noticed that more and more of my patients were being discharged to a SNF. So I said to myself one day, where are these people going? I think maybe I'll go find out. And I worked with a skilled nursing facility company that was taking a lot of our patients. And I found that their rehab team was very happy to have my expertise. They had not had a physiatrist on staff before, and they really weren't sometimes sure what to do with patients. The primary doctors working in the skilled nursing facility were definitely not rehab experts. The therapy team could not go to them and ask them a question about the rehab because the primary doctors didn't really know the answer. So the therapists were oftentimes put in the position of being the expert. And that sometimes put them in an uncomfortable situation. So they really appreciated having a physiatrist to come along and kind of help them with the rehabilitation aspects of the care that they were getting. More and more of these patients coming from our hospital. Um, However, will there be times when either the medical director, other physicians in the skilled nursing facility, the advanced practice providers, or even the therapists themselves don't really even understand your role or don't want you to be there? Absolutely, yes. I would say, and you'll hear from some of my other speakers that, we're somewhat of an unknown quantity sometimes when we walk into a skilled nursing facility. So that can definitely happen. That it's not like walking into an IRF where you'll find that everything is very similar. The intensity of rehab is similar. The quality of rehab is similar. If you've seen one SNF, you've seen one SNF. That's what we say, because they're all different. So when you walk into a skilled nursing facility, they may not even really be doing much acute short-term rehab. They might be doing more long-term care. They might be doing a great amount of short-term rehab. So I think you have to take that into consideration. What is your skilled nursing facility? What's the environment that you're walking into? And then the next thing that I'll say that I think I learned over the years is that there's a need to standardize. When you go into an inpatient rehab facility anywhere across the country, you'll see that a lot of the protocols, the pathways, they're not always standardized, but they're pretty much consistent from one facility to another. The lengths of stay by diagnosis. I mean, some of that is even set by the payment system that we have now that basically pays a certain amount by inpatient rehabilitation length of stay in an IRF. That's really not the case at all in a SNF. SNFs do not have the same payment system, and we'll talk a little bit more about that as we go on. But you probably will need to explain, what you're doing there, how you can help, why you should be there when you walk into a skilled nursing facility for the first time. Many skilled nursing facilities across the country now have a physiatrist or have a physiatry component, and so they may be very familiar with what you do, but they may not be. So I think some of the keys to success when you're working with skilled nursing facilities, sorry, grab a little bit of water here, are that we want to maximize the quality of the rehab programs that are going on there, just like anywhere. We want to minimize lengths of stay. Now, your skilled nursing facilities may be in a situation where minimizing length of stay is not one of their primary goals. In fact, because they're paid a daily rate, they may find that they want to maximize length of stay. And so you may get some pushback in some of those areas. I think less these days as more facilities are doing short-term rehab and they're involved in post-acute networks, and they're getting some push to right-size their length of stay. But back in the day when there was a 100-day maximum for patients in a skilled nursing facility, a lot of times the skilled nursing facility was incentivized to go towards a more longer length of stay for patients. But we want, the other thing that we want to do, another key for our success, is to maximize discharges home. Skilled nursing facilities also oftentimes have a long-term care function. So they may be sometimes invested in having patients stay there in long-term care. That's not our goal. Our goal is usually to get people home. The other key to success, more and more, is to avoid unnecessary hospital readmissions. There's been a lot of attention paid to readmissions and how that costs systems money, and so that's clearly going to be a goal for everybody involved, is avoiding unnecessary hospital readmissions. So how do we do this? Well, we do it by standardizing pathways and protocols, and I'll talk about a couple of those, not in any detail, but just to kind of give you an idea of what I'm talking about. We do it by having a hands-on personalized approach to each case, just like you would in an inpatient rehab facility. You're really not doing anything any different there. It's basically a rehab approach, working with the interdisciplinary team, individualized rounding on the rehab patients. Frequency can be on a case-by-case basis. There's no hard and fast rule in a skilled nursing facility, but usually 2 or 3 times a week, maybe less if there's not much going on. One of the nice things about not having a mandate to be there is that you get to pick the frequency of how often you're going to see your patient. In an inpatient rehab facility, I know it's usually daily. In a skilled nursing facility, it's probably usually 2 or 3 times a week. We also participate in the team meetings. There are team meetings in a skilled nursing facility. They may not be called an interdisciplinary team meeting like you have in an inpatient rehab facility, but there's some kind of a meeting where the therapists are talking about, and the social workers and the case managers, talking about each particular case, what it's going to take to get them home. And we're going to be really working on minimizing discharge barriers. Like, what does it take to get this person home? What do we have to do to get this person to the next step? All right, let's talk about some pathways. I'm not going to go into these in any detail, but just to kind of mention here that some of the patients that you will not see in an inpatient rehab facility anymore, back in the day when I was a medical director 20, 30 years ago, we had a lot of cardiopulmonary rehab, CHF, COPD, general deconditioning. That's gone by the wayside. Those patients are pretty much all going to skilled nursing facility now, unless there's really a reason for them to be in the hospital. Because of the 60% rule, you're not going to see these patients. And so you need to develop some kind of a plan for them. What's it going to take to get them from point A to point B, some kind of steps that is going to be necessary. The same thing is true with stroke. A lot of strokes go to skilled nursing facilities. You might make a case, you might hear cases made that stroke rehab is better served in an inpatient rehab facility. There's some evidence to that effect, but I don't think it's 100% true always. And I think that a lot of patients end up in a skilled nursing facility after a stroke. A lot of it is payer choice, and they're there. So if you're the physiatrist seeing that patient with a stroke in a skilled nursing facility, you have to have a plan for what you're going to do to take care of them. And it's very much the same as what you would do in an inpatient rehab facility, but the structure may not be there. You'll see a lot of orthopedic patients in a skilled nursing facility. They're not going to the inpatient rehab facility at all pretty much anymore unless they meet very strict criteria such as they're over 85 years old, have a high BMI or bilateral. So for most of your typical total joint replacements, they're going to be seen by you in a skilled nursing facility. Much shorter length of stay, much quicker rehab. You might be seeing these people more frequently, but you need to come up with a plan. What do they do on day 1, 2, 3, 4, 5 to get them home? Hip fracture, again, you come up with a pathway. What's it going to take to get the patient home? So the skilled nursing facilities are being challenged to provide lower lengths of stay. I think I alluded to that earlier. If they're in a post-acute network, certainly their post-acute network is saying, these post-acute costs are driving our costs up. And so we want lower lengths of stay. We want reduced discharges back to acute. You can't just take this patient who's sick and say, oh, we're going to send them right back to the ER. That's not going to work. They're being challenged to provide lower 30-day readmissions. That's something that they're being measured on. So the number of patients that get readmitted to the hospital within 30 days is certainly something that they're going to be looking at. And they are going to be looking at quality rehab outcomes, although unfortunately, there really is no outcome measurement that sticks, so to speak. But clearly, that's our goal, is to have quality rehab outcomes in this patient population. So I want to give you a little bit of data. I'm not going to bore you with this too much, but this is a small study that was done by us showing that the effect of a physiatrist, particularly an IRC physiatrist, in a skilled nursing facility reduced the 30-day emergency department visits, reduced the hospital readmissions. You can see that on the far right lower corner, and also at the same time, reduced the lengths of stay and increased the acuity of the patient. That's in this case, it was the RUG mix per nursing day. That system has now gone by the wayside in preference to PDPM, which we'll talk about in a minute. But this study, a couple years old, showed that the effect of a physiatrist really fell in line quite a bit with what the skilled nursing facilities were trying to do, particularly those that were existing in a post-acute network. Here's another study. This is actually from our own Northwestern Hospital post-acute network here in the Chicago area, that showed that the physiatrist, particularly the IRC physiatrist next to a competitor physiatrist and a control group, we had a reduced average length of stay in the post-acute network and a reduced hospital readmission rate. Nice to be able to show that kind of data. I want to take just the last couple of minutes here to wrap up and talk about the PDPM model. You may or may not be familiar with that. It's essentially a payment model,
29-inch, okay.
A move towards prospective payment in the skilled nursing facility, and SNFs are being paid based on patient characteristics now rather than therapy minutes, which was the case in the past. When they were being paid by therapy minutes, the goal of most SNFs in the country was to maximize the minutes of therapy. Now,
Yours is
they're really
study.
looking for
Oh, okay, nothing.
outcome measures. There's no unified outcome measure, but they're looking for patient characteristics that land these patients into categories that will then pay the skilled nursing facility based on those patient characteristics. So I came up with a couple of theoretical case studies. These are not real patients, but they're similar to real patients that I've seen. Here's a 76-year-old female coming in for basically what is COPD exacerbation, generally deconditioned, weak. She had a prior stroke, got mild residual hemiparesis, poor balance and coordination, cognitive impairment, and some mild dysphagia. So the skilled nursing facility looks at the discharge diagnoses from the hospital, and here they are, COPD and pneumonia. And their PDPM daily rate for this person to come into the skilled nursing facility is based on those hospital discharge diagnoses. But what we do is we start fleshing out, if you will, that the more full picture of this patient's characteristics. They're going to need some additional services because of things like their dependency, their nursing needs, their dysphagia, And so if we start to add those ICD-10 codes into the patient mix for the facility gets a bigger market basket of their reimbursement goes up based on what those patient needs are. Here's another example. Oh, I'm sorry. So in this case, the PDPM daily rate increased about $84 based on what the physiatrist had added in terms of the characteristics for the PDPM model. Second case is an 87-year-old with a hip fracture and routine healing, also has BPH, but has a history of diabetes, neuropathy, poor balance, coordination, some mild dementia, some urinary retention, and requires intermittent bladder catheterization. So the diagnoses that show up from the hospital when the patient's admitted are a hip fracture and BPH. However, when the physiatrist sees the patient, they start to add some things like poor balance, mild dementia, some therapy issues, wound issues. So these are things, this is not all something that the physiatrist can add. Maybe the dementia was picked up by the speech therapist, or the wound care brought in some of these other diagnoses. But we highlight them, and we then present a more full picture of what this patient needs in their rehabilitation. So again, the PDPM daily rate for based on the hospital discharges alone was $554. When you start adding in these other ICD-10 codes and you more fully flesh out the patient characteristics, you find that, in fact, the facility does better financially in this case. I want to point your attention to a couple of resources that you can look at. One is the Academy's own position statement, the physiatrist role in skilled nursing facilities. It's available on the Academy website. And I think it's good reading if you're interested in this area of patient care. You probably want to start with this position statement. There is more information on PDPM that you can get, but the only reason I really bring it up is to kind of fully show you some of the things that add into the value of the physiatrist in the skilled nursing facility. So long story short, what do? We're working with our healthcare systems. You're probably associated with a hospital, maybe an ACO, maybe they have a post-acute network. They're trying to get the patient out of the hospital as quick as they possibly can and get them to the next level of care. We want to help them understand and manage that post-acute network. We want to obtain the best outcomes for our patients. We want to utilize less resources along the way and be good stewards of those resources for society and everybody. And we want to demonstrate the value of physiatry in the skilled nursing facility and in all post-acute settings. I think it's important to recognize that skilled nursing facility rehab really is a transitional phase. There's more of a movement towards home health and outpatient and getting people out of institutions in general, right? Nobody wants to be in an inpatient institution for rehab any longer than they have to. But the advantage of being in an inpatient institution is that you have all the resources there. You have the therapists are all there, the equipment's there. Try to reproduce that sometimes in home health or outpatient environment is much more difficult. So we as physiatrists have to demonstrate our value in all these post-acute levels of care. I don't think it's limited to just acute inpatient rehab or to skilled nursing facility rehab because we really want to help patients become independent and minimize disability. So we want to guide the rehab for our patients in all settings to maximize their functional outcomes and have them live a productive life and a functional life and one that's free of pain and where they can do well. And we also want to help guide our health systems and healthcare as a whole so that the post-acute care of people, getting them back to their lives, is not terribly expensive, not something that breaks the bank of the healthcare system. And then, of course, while we're doing it, we want to have fun and not burn out and just take care of patients. So with that, I'm going to turn this over to my esteemed colleagues, and I want to thank you. And that concludes my portion of this conference. Thank you.
All right. Well, good morning or afternoon, whenever you may be watching this. I'm Charlotte Smith, and I'm actually dialing in from sunny Seattle.